Good morning. In this video, I want to show and explain a surgical procedure I've already discussed in the past. Specifically, I'll talk about osteotomy, a word meaning a cut in the bone to shorten the first metatarsal. This is a good surgical procedure that I perform in cases of osteoarthritis between the first metatarsal and the phalanx of the big toe. However, to plan this surgery, we must have arthritis that is not too advanced. I therefore refer you to the previous video for a clearer understanding of the various surgical and treatment options for big toe osteoarthritis. Surgery is performed under long-lasting anesthesia in the calf. The cut in the skin is about 8–10 centimeters long and is made on the inside of the foot, targeting the metatarsophalangeal joint of the big toe. To prevent blood loss during the procedure, a pneumatic tourniquet is placed at the ankle, which is covered by sterile sheets. The few arteries or veins that may leak a few drops of blood are easily coagulated, i.e., burned, with this instrument, which we call bipolar. After this first phase, we reach the joint capsule, a very thick and resistant tissue that envelops the entire joint. The joint capsule is easily identified and is then cut lengthwise. The joint capsule is an important structure that must be reconstructed at the end of the surgery. Therefore, at this stage, it is crucial to cut it as precisely as possible using a scalpel, trying to keep the blade in close contact with the bone to preserve the joint capsule. Once the capsule is opened, both above and below, we have a perfect view of the metatarsal bone and the phalanx, and therefore also of the entire joint. The first phase of the surgery consists of removing the osteophytes, that is, the protrusions of bone on the upper part of the first metatarsal that often cause pain due to rubbing against the shoe, which also causes redness at that level. To remove these bony protrusions, we use a small saw to easily remove the excess bone. The next step is to plan the osteotomy of the first metatarsal, following the plan we already made on the X-rays before starting the operation. Before performing the osteotomy, we place instruments called retractors on both sides to protect structures such as blood vessels, nerves, and tendons. Bone is a very hard and resistant tissue, so we must necessarily use a motorized instrument such as a saw. This is the small saw we use. It's a sterile, high-powered instrument with a very thin blade, less than 0.5 millimeter thick. After drawing the cutting line on the bone, we'll use the saw following this line to be as precise as possible based on the X-ray plan. The bone must be cut completely, that is, from side to side, to allow for easy mobilization of the head of the first metatarsal. As you can see in these images, the head, that is, the smallest fragment, can be easily mobilized, and once the optimal position has been reached, that is, the one established by the preoperative plan, it is temporarily held in place by a metal wire called a Kirschner wire. The visible bone edge is generally 2–4 millimeter long and is obviously removed using the motorized saw. Again, we've now inserted 2 more Kirschner wires, slightly smaller than the first, and these 2 Kirschner wires will guide the 2 screws we'll use for definitive bone stabilization. After inserting the Kirschner wire, we use this tool to measure the length of the screw for both the first and second screws. The final screws can be made of either metal or absorbable material, which means that they will dissolve on their own over the next 9–12 months. Metal screws can theoretically cause discomfort and therefore may require removal in a second surgery. After inserting the last screw, we evaluate the stability of the osteotomy, the degree of joint mobility, and the degree of joint release. Naturally, we also always perform an X-ray to ensure the correct position of the bone fragments stabilized with the 2 screws. At this point, the surgery is practically complete. We use absorbable suture, which dissolves on its own, to place the first stitches on the joint capsule, trying to keep it as attached to the bone as possible. The number of stitches placed on the capsule varies based on the length of the incision, but generally there are 4 or 5 stitches, keeping the toe slightly bent downward. The same goes for the skin. In this case too, we use a slightly different absorbable suture thread than the one we used before for the capsule, because this thread tends to dissolve and fall out sooner, generally 2 or 3 weeks after surgery. Although it is very rare, tell your surgeon if you have had an allergic reaction to absorbable sutures in the past, because in that case, we will choose a different type of material, such as nylon. In this case, obviously the stitches will not be absorbable, but will have to be removed after 2 weeks. Once the skin has been sutured, we begin the dressing. The first layer consists of sterile plasters. Again, if you know you have an allergy to plasters, you must immediately inform your surgeon to avoid using them after the operation. Immediately over the plasters, we place 1 or 2 layers of sterile gauze to protect the dressing from any contamination, even in the event of bleeding. Over the sterile gauze, we then apply 1 or 2 layers of elastic adhesive bandage to provide stability to the entire dressing, even when the patient begins walking. This type of dressing will be redone once a week. However, subsequent dressings will be less thick than the one you just saw.